Thank you for the privilege of speaking to this group. I look forward to it. America's Health Rankings, see the big button here. I just want to talk first about is we are kind of the rear view mirror compared to where 2030 has to be looking for the windshield. So we have to take what's available and put it into an action platform that can be used by the states in order to monitor what's going on now. So in many ways, we are one of the big users for it. We support a platform that publishes 4 reports every year, 3 of them by every state, compares every state against each other for either annual overall population or for seniors, which just came out a few weeks ago, or for health of women and children. We also support an outreach program that many of you may not be realized, but we reach out to all the states and many people individually on a one-on-one, state-on-state basis to present the data to them. So we take a lot of our stuff and reformat it, and especially go into deeper dives for stuff that's not in the reports, in with individual state health officers and their committees. So those 2 things take about equal amount of time. So we put a lot of our time in outreach, which people don't see.
That's great.
And so we get a lot of feedback about how much they hate us or how much they love us, depending upon where they're at, and why they changed. The other thing we support is obviously the website for all the data. So I think also it's important that we have different objectives than HP 2030 does. And I just want to go through those a little bit so that you understand where I'm coming from, so it may be a different perspective. We have some public health objectives. You know, we want to start a conversation. We don't want to finish it. We don't want to even we want to start the conversation. It's very important to us that it's multiple sector conversation. We also want to provide an overall construct so that people can see where their interests fit within a bigger picture. One of the biggest uses that we get feedback we're the first paragraph of many introductions say, well, we rank this place in the state or in this, and now let's look at my area. And that's the construct that we intentionally want to create, is where this thing fits in a larger picture. We believe that it should have solid science background. And I put that in there, not saying absolute science, not like rigorous science, just sound, solid. Because we have to balance communications with science. And sometimes we have to pick a measure that we may not want to use ideally, but it's much better to communicate. So we have to run that balance between science and communications all the time with all the measures we use. And we do look for the continuity and longitudinal comparison. States look about how they do over the time, both in our overall ranking and also in each of the subcomponents. We have always said that our big idea is the rank is really the news getter, the meat of our conversation is the second line. What has changed? Why is that rank different there? And that's what we really try to get the communications go to, that second line. When we go about communications, we want reach, recognition, plain language, and flexibility. We need the flexibility is really important when you go to the outreach. That's where we see a lot more of it. How can we manipulate our data to be used in different areas? And we've been, in the last 2 or 3 years, we've done a conscious effort to move everything into plain language, which is much simpler sounding than it really is. And then also, we initially, the first decade was funded by Northwestern National Life, which is now ING, I believe, which was a health insurance company at the time. And we're now funded by United Health Foundation, which is funded by a health insurance company. So understanding where our relationship is, that they have their objectives, they use this to build relationships. So that's their objective, is not to necessarily rank states, but to build relationships with providers within states. And they use this to support their philanthropy efforts and also to add brand to their value. So that comes back into us when we publish stuff. We submit our report to it and stuff like that. And they don't edit our reports substantially, but our communications, you'll see sometimes the communications and reports may be a little bit different. And so you see that we have that objective coming from the foundation, so kind of put that in perspective, if you will. So what do we use here? I'm not going to explain this. We use a model to create our rankings. You know, we have, and I think Pat Remington's famous saying, all models are wrong, but some are useful. But I think this is the useful category. We put things in 5 categories. And I bring this up now because when we pick measures, this becomes very instrumental in how we select measures. Because our intention is to populate each area approximately in a holistic way, not just put one area thing, but put 3 or 4 or 5 measures in each area. Even if that area doesn't necessarily have a strong support in the overall health picture, if you will, so that we can talk about each of these areas in somewhat robustness rather than narrowness. So this started back from when he did 1990, where back then putting the idea of putting health risk factors in a model was kind of like, well, just measure mortality and morbidity. That's all you need to worry about. And we at that time forced a 50% on health with determinants, health risks, determinants, which was kind of novel at the point. And we've since then forced measures to go into certain categories just so that we can talk about those categories and keep them present in the discussion across this multi-sectorial area. And so I'm not going to go through this. Our model is a little bit like other people, a little bit different. County health rankings is basically very close to the Kindig model, which is in the upper left-hand corner. We also use, but our model is similar to it, but different. We use some plain language. We pulled out genetics, obviously, because we can't measure that. But we kept the general balance of each other as we go through in our model. The reason I bring all this model up interesting is we're changing, and we'll be changing later this year, possibly, hopefully, if all goes well. We currently have behaviors, community environment, policy, clinical care as the determinants, and a group of mortality measures as outcomes. We have elected, with the help of our scientific advisory committees, to shift away from putting policy as a category and move it into all the other ones where it's applicable, where what the policy applies to, rather than calling it out separately, put them in all the different categories. And we've broken off community environment into two areas, social and economic factors and physical environment. So going forward, just because of the way we put measures in, we're going to end up more and more measures in those in that new category than we did in community environment, just to start representing the importance of SDOH on health. So just by restructuring our model, the way we select measures that go through is we're going to move more and more into that area as a gradual evolution. And I just want to put a note here is we get the advantage here that we have a model we put together for our reports. This is a model of how we're going to calculate the rank of a state. This is not necessarily a model of health. So I don't want somebody to go through and adopt this as a model of health. We don't have good disparity and inequity information in this model at all. We try to include it where we can in individual measures, but it's one area that I feel that we are lacking in. So it's really model how we're creating health. We're creating our rankings, not necessarily how we should do health overall. So there's a shortcoming that way. What's a selection process? I'm going to try to do this in 2 slides, making it sound like it's a nice, neat process. It is not. But basically, we create a laundry list of measures, and we have to look for available data. We don't have the luxury of creating data. We don't have any primary data at all. Ours is all secondary data. In here, we go through, it's clearly connected to health through literature searches. We need it both national, state level. We prefer annual data if possible because we update every year. We do to use biannual data. We will reject a data source unless it's really, really good for anything that's not updated at least biannually. We also have a requirement, we want publicly available data. We want to be able to tell the person that if you want to go look at this data source, go ahead. You want more details on it, go to the data source. We don't want to use data that is not readily available to other people. That doesn't mean that anybody can use it. Some of it's complex to get to, but it's got to be readily available. We go for understandable. Earlier, one of our measures is years of potential life loss before age 75. We call it premature death. We go for measures that we have some that are just too tough to communicate that we'd love to do, we're interested in doing, but we do it. We prefer single item measures, but I'm going to talk about where we compromise on that pretty severely as we go through a model. But we ideally like one thing, so you can point at one thing and look at the intervention, what's going on. Interstates, obviously comparability. From our source, we're a group of 7, and so we have to have very reasonable analytic requirements in order to produce the report. So we're not going to do a whole lot of heavy lifting. We look at quality and reputation of the source. We look for continuous rather than binary data. We do have one measure in there. We have measures in one report about hospital associated infections, which says which ones are they reporting on, which numbers to report on. So it gives you 1 through 6 as a score, but we'd rather have a continuous rate measure because it's easier to compare states, easier to talk about. And we do a bias toward actionability, but that's a bias toward it. If there's something we can't figure that's actionable, sometimes we still have to include it. So what do? We take all these laundry lists and we throw it into one of the areas of the model. And sometimes they fall into 2 or 3. And so we put them in where we want to need them. We also use proxies when we know we would like to have something that's not there, but we need a thing. One I put there is drug deaths is in the behavior category. It's not. When you're dead, it's not a behavior. But we using that as a proxy for adverse drug usage. Here's a place where we're doing a lot more of creating summary measures, where we actually roll up all the immunization for adolescents into one measure. We are finding that this is helping us in several ways. It allows us to get across, I think in that case, 3 different immunizations, and to talk about it as a category so it's easier to communicate than talk about each one individually. It also, immunization in adolescents gets us away from a hot topic. HPV is a hot topic for conversation, but when we talk about adolescent immunizations, it's a good topic to get started on. And at least for a lot of communications, that's as far as they're going to go. And so it allows us to broach topics that necessarily can't be hit when you use just individual metrics. We also have started in the last couple of years, I'm going to talk about risk for social isolation. That's actually an accumulation of 5 census measures that was put together by AARP as a measure for senior risk of social isolation. We're starting to use that because it's a much more powerful communication message than living alone, widowed, divorced, and all these other things accumulate underneath it. It's these compound effects that's going on, that it's not one thing. Somebody says, well, we know a person that got away from that effect. But you say, well, it's a compound effect. It's like multiple chronic diseases versus single chronic disease. So we're going to more and more to combining measures. We now have 2 in our models. We have this one. We have also concentrated disadvantage that we use for women of childbearing age, which again, it's 4 or 5 poverty measures and household constituency measures roll into one that talk about one issue, and that's the concentration disadvantage. It allows us to talk about more subjects and get a bigger, complete picture, and still talk about the subject as a unity rather than as just little different things that they have to work on. It also allows people to approach the solution side from many different angles. It doesn't dictate, well, like for adolescent immunization, I got to increase my rate in this. No, you can do a whole immunization program, so you can approach the intervention broader. And we now are moving more to cascading and nesting measures, where this is what we're going toward is, so we have years of potential life lost. In the next year or 2, we're going to actually just have that breakout wall due to cancer, due to other different things. So we're not going to add a new measure, consolidation. We're just going to tell the people, start there and break out. And rather than putting a key indicator in our thing as all of them, we're just breaking them out. We actually do this now with infectious disease. Then we actually, after categorize everything into one area, we then try to manage each area of the model. We try to minimize overlap. We try to optimize the number of a category, 4 to 6. Now you see this is where our model categories become key, because we're now putting 4 to 6 measures in each one of those categories. So when we now split that social determinants into 2 categories, it means to build up our selection process, there's more chance of some of these getting in, if you will. And then we also prioritize things where we can get subpopulation data or sub-measures underneath it. That helps us bring a measure in, because that gives us depth of talking about it when somebody starts to use it as an issue. We then review the whole set for overall the whole breadth. And here's where we go back and say, did we catch the breadth of the sectors we wanted? And this occasion has allowed us to recommend measures to move from one category to another, or change the measures so that another sector is the one that's kind of identified as the key component of it, and reduce overlap. We use a scientific advisory committee. We have a council that advises us on the overall guidelines that we just recently reconfigured. We have 1 for each report, so we have 5 committees to work with. It's fun. When we do an initial report, like when we came up with the senior report, or actually the original one too, is we actually use a modified Delphi process for the initial design, very close to what the first speaker said. We put out a set of base measures. We ask what's important. We ask for prioritization, and we do that. And so that's how we get to this group of measures type of thing. And then when we actually roll out things, we actually introduce things to people we call as a supplemental measure. We kind of get people used to the nomenclature. We test for how it reacts. We look for reactions to it, questions we have about it. This is a great place where we start renaming measures because it's confusing, or things like that. So we actually roll things first as a supplemental measure. And also because we're in continuity with the state health officers, this is also the signal to them that next year this could be in your grade card. So beware, it's coming. So we do that to do it. So, whoop, I'm out of time. I'm going to go back to this one thing is, I want to go through with one challenge, and just to bring up one thing is, I think the big thing that I would think here is simplicity of the measures you come as leading health indicators. Who you want to talk to and what you want to say to them. We talk a lot about plain English, precision of it's got to be precise, but not understandable on our definitions. So that whole plain language consolidation is what really drives a lot of that. So
Thank you.
that's on you.